Good afternoon and welcome to everybody. I'm Tom Bailey, Dean of the University of Washington School of Pharmacy. And as Chair of the Board of Health Sciences Deans, it's my pleasure to welcome you all to the 20th John R. Hogness Symposium. This symposium series was established in 1979 by the University of Washington Board of Regents to honor Dr. John Hogness. Dr. Hogness, who passed away in 2007, had a remarkably distinguished career as a physician, a teacher, a researcher, and university administrator. The 6 health science schools here at the University of Washington, namely dentistry, medicine, nursing, pharmacy, public health, and social work, all participate in planning this important symposium event. So now let me introduce Dr. Noel Chrisman from the 2011 John R. Hogness Symposium Planning Committee. He's also Professor, Psychosocial and Community Health, University of Washington School of Nursing, who will introduce this year's speaker, who is Professor David Williams. Dr. Chrisman.
Thank you, Dean Bailey, and welcome to all of you. It's going to be an exciting afternoon. Dr. Williams is the Florence and Laura Norman Professor of Public Health at Harvard University. We could spend the rest of the time reading through the rest of his vita, but I think we'd all much rather hear him speak about making America healthier, simple and surprising steps for every health professional. Welcome, Dr. Williams.
Thank you very much for the kind words of introduction, and thank you to the Planning Committee for the invitation to join you for this important lecture today. So we want to begin by thinking about where America's health is today. We spend more money on medical care, absolutely and per person, than any other country in the world. But the return that we get from this expenditure is not, in fact, substantial. The U.S. ranks near the bottom of the industrialized world on health, and we are losing ground over time. For example, in 1960, we ranked 11th in the world on infant mortality. In 2004, we were ranked 29th. Countries like Cuba, Korea, the Czech Republic, Greece, and Northern Ireland and Hungary have a lower infant mortality rate than the U.S. did. And it's not just that the minorities are doing badly. In 2004, if white America were a country, it would rank 26th in the world. Black America, if it were a country, would have ranked 36th. If you look at life expectancy, we see a similar pattern. In 2006, we ranked 33rd in the world, behind countries like Cyprus, the United Arab Emirates, South Korea, Costa Rica, and Portugal. Again, white America as a country would have ranked 30th. Black America would be 58th. But a really important point that I want to begin with is that all Americans are far less healthy than we could or should be. So the challenge of improving America's health is a challenge that all of us face. To illustrate that, I'm using a slide here from the work of the Robert Wood Johnson Foundation's Commission to Build a Healthy America that provided state-by-state chart books on child and adult health. And this slide shows the percent of adults in the great state of Washington who are in less than very good health, a widely used global indicator of the health status of a population. And what it shows is that health varies in the state of Washington by socioeconomic status, as captured by educational level, and health varies in the state of Washington also by race and ethnicity. But the important take-home point is that for these chart books, we identified a national benchmark. It's a level of health that a group of Americans are achieving today. There's no reason why all Americans are not achieving the same level of health. And using this national benchmark, all groups in the state of Washington, even the college-educated, persons of all racial groups, are not achieving a national benchmark that is possible for persons in the state of Washington today. In addition, there are large socioeconomic status differences in health, and they are an important point to help us to understand some of the variations in health that occur. In virtually every country of the world where we have data, SES, measured by income, education, occupational status, is one of the most powerful predictors of variations in health. and the United States is no exception to that pattern. Here is an example of the kind of data we have for the US. National data on premature death, that is death before the age of 65 by family income. And what is evident here is that every higher level of family income, premature mortality is lower. It's not just a threshold effect. It's not just that the poor are doing poorly, but every higher level of income, it's a gradient effect, is associated with better health. And even if you look at middle-income Americans in this chart, you can see that middle-income Americans have twice the level of premature mortality, death before the age of 65, compared to high-income Americans. And I just want to give you a couple other examples that this is not just for premature mortality, it's for a broad range of indicators of health status and health service utilization. So here's national data for the US. Lung cancer mortality, lung cancer, the #1 killer in the United States. By the way, lung cancer kills more Americans every year than any other cancer. Lung cancer kills more American women every year than any other cancer. You heard me right. Lung cancer kills more American women than breast cancer does. In fact, lung cancer kills more Americans every year than breast cancer, colorectal cancer, prostate cancer, and pancreatic cancer combined. So it is, in fact, a major source of preventable deaths in the US. But looking at lung cancer mortality, what's evident here is, for example, among white men who have less than 8 years of education are 10 times more likely to die, a tenfold difference in mortality compared to white males who have a master's degree or more education. Huge variation. Here is another example. The percent of Americans with a dental visit in the last year. And I'm showing the data by race and ethnicity from the National Healthcare Disparities Report. And what you can find is the powerful pattern of every higher level of income is associated with higher rates of having seen a dentist in the past year. But what is also evident in these data, the challenge that all of us can be doing better, is that even the best off Americans, those with income 4 times the poverty level, other than whites, where only 60% of high-income Americans see high-income white Americans see a dentist in the past year. For all other groups, it's less than 50% see a dentist in the past year, suggesting the high level of unmet need in the population in terms of dental care. Why does socioeconomic status matter so much? Well, we know that socioeconomic status predicts the level of education in early life. It affects the quality of employment opportunities. It affects the quality of residence, of housing, of neighborhood conditions, the quality of life in retirement. Basically, from the cradle to the grave, socioeconomic status shapes the opportunities to be healthy. And because of the central role that socioeconomic status plays, there are, in fact, large racial differences in health in the United States. Because race, in part, captures dramatic variation by socioeconomic status. To illustrate this, I'm showing you national data on the percent of persons who are poor by race and ethnicity. And you could see that African Americans, American Indians, Hispanics have markedly higher rates of poverty than whites do. It's important to keep in mind that although the rate of poverty is higher, most poor Americans are white. And there are twice as many poor whites than poor Latinos, and twice as many poor whites than poor African Americans. So when we're talking about socioeconomic status, we're talking about a factor that cuts across all population groups. And because of these racial variations in socioeconomic status, there are, in fact, large racial differences in health. The pattern is most pronounced for African Americans and American Indians, where they have higher age-specific death rates than whites from birth through the retirement years. So what's important about that is that the problem of ill health is not restricted to one stage of the life course, but it is across the life course. Hispanics also have higher death rates than whites for certain select conditions like diabetes, hypertension, liver cirrhosis, and homicide. Asians have an overall lower death rate than whites, but that has to be contextualized into the context of immigration that I will talk about in a minute. Minorities not only have higher death rates, but they get sick at younger ages, have more severe illness, and they die sooner. So understanding the health profile with national mortality data for Asians and for Latinos, we need to understand the role of migration. Immigrants of all racial ethnic groups in national data for the US have better health than their native-born counterparts. White immigrants have better health than whites born in the US. Black immigrants are better than blacks born in the US. Asian immigrants are better than Asians born here. Latino immigrants are better than Latinos born here. However, with increasing length of stay in the US, the health advantage of immigrants declines. It's as if the data is telling us that the American way of life is dangerous to your health. And the longer people stay here, the worse their health becomes. This is really true. That's what the pattern that the data suggests. I think, though, as we look to the future, the challenges are likely to be much more pronounced for Latino immigrants and Asian immigrants because the levels of human capital as captured by the levels of education is very different for these two population groups. Here is an example with mental health data, the prevalence of DSM-4 defined psychiatric disorder, national data for the US looking at immigrants of three groups: Caribbean black immigrants, Latino immigrants, and Asian immigrants. And what is contrasted here is the prevalence level in the first generation, persons who are immigrants born outside the US, migrated to the US. Second generation, persons born in the US, but their parents were immigrants. And third generation, persons born in the US whose grandparents were immigrants. And for Latinos and Caribbean blacks, you see this dramatic increased prevalence of psychiatric disorder as you move from the first to the second to the third generation. For Asians, you see the pronounced increased risk from the first to the second generation. One example that exists for multiple indicators of health, of worsening health status with generational status over time. The larger issue that we need to understand for the broad range of health outcomes is what are the relevant factors and what is the contribution of multiple factors in shaping this dramatic worsening health profile that we see for immigrants in the US. And also, what then might be the interventions that we can implement to reverse this downward trajectory in terms of health. So I made the point that racial disparities exist. Not only do they exist, but they have actually existed for a long time. There is good news and bad news with that finding. First is that we haven't made as much progress as we would like, but it's also important to keep in mind that for many outcomes, things are getting better over time. The absolute rates are going down, and we should celebrate the progress we have made. We should identify what are the factors responsible for the progress so that we can build on them and accelerate the progress that has been made. I want to illustrate the progress has been made by looking at American Indian death rates over time. And here we see an example of declining death rates for American Indians for homicide mortality, even though their rates remain higher than that of the white population. Here, for alcohol-related mortality, we also see a pattern of declining death rates for American Indians over time. So even though the disparities exist, progress is being made, and we need to celebrate the progress that has been made. For some outcomes, though, for American Indians, you can see worsening health. Lung cancer mortality going up, and diabetes mortality also going up. So there's progress in some areas, but challenges remain in others. For blacks and whites, we have data for a considerable period of time. So here's life expectancy for blacks and whites in 1950 and all the way through 2006. What is evident here is the good news. The gap in 2006 is smaller than it was in 1950. On the other hand, it still exists. Another way to think of the racial disparities in health is to look at the health of whites in 1950. 69.1 years life expectancy at birth, and ask how long did it take for African Americans to catch up to the health that whites had in 1950. And it wasn't until 1990, 40 years later, that blacks caught up to the health that whites had in 1950. And in all of the comparisons in this chart, there's a 30 to 40 year difference in life expectancy for two groups living in the same society. At one point, early in my career, researchers thought that the racial differences in health, which are profoundly influenced by socioeconomic status differences across race, were fully responsible for the racial differences that occurred. And we believed that statistically, if we could only adjust for socioeconomic status, we would completely erase racial differences in health. We have since learned that the pattern is more complex. I want to give you a few quick examples to illustrate the challenges that exist. So here is life expectancy at birth, life expectancy at age 25 for African Americans and whites. And you can see there's a 5-year difference at age 25. However, if we look at the difference within whites by education, you find there is a 6.4-year difference between low education whites and high education whites, and a similar 5.3-year difference between blacks of high and low education. Importantly, the differences in health within each race by education, is also true by income, I'm not showing you the data, are larger than the overall racial differences in health. At the same time, at every level of education, there's a persistence of the racial gap. And the racial gap is larger at the higher levels of education than at the lower levels. Give you another example of a persistence of a racial difference even after we've controlled on socioeconomic status. Here is data from a cohort of all white physicians trained at Johns Hopkins University and all black physicians trained at Meharry Medical School. Around the same time, they're all of the same social class because they're all medical doctors practicing in the United States. 23 to 25 years later, the black doctors have a higher risk of cardiovascular disease. They have an earlier onset of disease. They have incidence rates of diabetes and hypertension twice as high as their white physicians, higher incidence of coronary artery disease, and dramatically higher case fatality rates. How do we make sense of this persistence of a racial difference even after we've taken socioeconomic status into account? Research has identified that there are 3 factors operative. One of them is we've got to take the life course into account. The health of adults is shaped not only by their current socioeconomic status and social experiences, but by what they have been exposed to over their entire life course. A second factor is all indicators of socioeconomic status are not equivalent across race. I'll elaborate on that in a minute. And thirdly, we have to address the ways in which racism continues to matter in terms of health. So what do I mean by the non-equivalence of socioeconomic status across race? National data reveal that compared to whites, blacks and Hispanics receive less income at the same levels of education, have less wealth at equivalent levels of income, and have less purchasing power. Although on average they tend to live in poorer neighborhoods, the cost of goods and services are higher in those disadvantaged contexts in which they reside. So $1 in the hands of a black or Latino, and I would argue the data didn't show it for American Indians, but American Indians face the same challenge, doesn't buy as much as $1 in the hands of a white person on average. Let me give you one example of this non-equivalence with actual data from the census. This is wealth, or median net worth. This is not income, which is the flow of resources into the household. Net worth captures the economic reserves that a household has. And you can see that on average in the US, the average white family has $79,000 in net worth. For every dollar of wealth that whites have, blacks have 9 cents and Latinos have 12 cents. If you look at poor Americans, the lowest quintile of income, so we are now statistically taking income into account. For the poorest 20% of the US population, let's call them poor, poor whites on average have $24,000 in wealth. For every dollar of wealth poor whites have, poor Latinos have 2 cents, and poor African Americans have 1 penny. And if you look at the richest Americans, top quintile of income, rich whites have $208,000 in wealth on average. For every dollar of wealth that rich whites have, rich blacks have 31 cents and rich Latinos have 35 cents. It's a dramatic example that when we only look at income, we dramatically understate racial differences in economic circumstances. So a third reason why we find this excess levels of ill health is the added burden of racism. I have time today to only talk about 2 examples of racism. But I want to show you a striking pattern that illustrates that there's something distinctive about the experience of disadvantaged populations in multiple countries. I'm showing you life expectancy differences for indigenous populations, the Maori population from New Zealand, the Aboriginal population from Australia, the First Nations populations in Canada, and American Indians and Alaska Natives in the United States. And across very different societal contexts, you see indigenous men having lower life expectancy than the majority population in their society. The similar pattern is true for indigenous women. And in fact, as you look across specific causes of death, there are 3 causes of death that stand out in each of those societies where the indigenous population does worse. What is shown here is the risk ratios. So in New Zealand, the Maori population have a death rate from diabetes that is 5.7 times higher than that of the general population of New Zealand. In Australia, it's 9.8 times higher for the Aboriginal population. In the US, in Canada, it's 1.5 times higher for the First Nations population. In the US, 2.2 times higher. And for diabetes, suicide, and homicide, we see this pronounced pattern. What that means is we need to step back and begin to think about what is constant across these very different societal contexts where we see the same pattern of disease for different populations, but different non-dominant populations, different stigmatized populations, different economically exploited populations in very different contexts. And one of those differences is the racism that exists across these contexts. Now, you're a much more sophisticated audience here at the University of Washington, but I teach undergraduate students. I've taught them for the last 2 decades. And my students are all born after the 1960s. And they believe that discrimination was something that used to happen in the United States. But since Martin Luther King and the Civil Rights Movement, discrimination no longer occurs. Some of the best evidence that discrimination persists in the US comes from what are called audit studies. You hold everything identical and you vary only the race. Deva Pager, sociologist now at Princeton University, this is a doctoral dissertation at the University of Wisconsin-Madison, sent pairs of 2 African-American males and 2 white males to apply for entry-level jobs in Milwaukee, Wisconsin. She had one of the white males and one of the African-American males indicate on their resume that they had served an 18-month prison sentence for cocaine possession, so they had a criminal record. She found what you would expect to find, that whether you were white or black, if you had a criminal record, you were less likely to get a call back for a job. She found something we didn't expect to find, and that was, it was easier for a white male with a criminal record to get a call back for a job than a black male whose record was clean. The resumes were identical. The only thing that differed was the race of the person handing in the resume. Deva Pager replicated her study in New York City in 2004 using whites, Latinos, and blacks, and also found that it was easier for a white with a felony conviction to get a call back for a job than a Latino male or an African-American male with a clean record. Powerful evidence of the persistence of discrimination in the United States. Research documents that discrimination matters in multiple ways, through institutional mechanisms, through segregation, through reduced access to goods and services, through internalized racism, through exposure to stress, and through experiences of discrimination. I will touch briefly on only 2 of the mechanisms. One is residential segregation by race and how that continues to affect health through multiple mechanisms. Where you live shapes your access to good quality education. It shapes your access to employment opportunities. It shapes the quality of housing conditions, the quality of neighborhood environments. It shapes your access to medical care in the United States. David Cutler, a former speaker in this great lecture that I'm giving today, has done seminal work looking at the impact of segregation. And he found, using national data, that if we could eliminate the effect of residential segregation by race in the US, we would completely erase black-white differences in income, education, and unemployment, and reduce black-white differences in single motherhoods by 2/3. How segregated is the U.S.? In South Africa, under legally mandated apartheid in 1991, the segregation score for that country was 90, meaning that 90% of black South Africans would have to move to have an even distribution of blacks and whites in that society. In the year 2000, the 2000 census, most of America's largest cities had levels of segregation only slightly lower than that under legally mandated apartheid in South Africa. So segregation is a powerful determinant of health. We'll talk about what we can do about it in a minute. Another way in which racism affects health is through the subjective experiences of discrimination. Selina Mohammed, who is here today, and I did a review of recent research on perceived discrimination in health. We found just in 3 years, between 2005 and 2007, 115 new studies. We have studies that now have addressed many of the limitations of the prior research. There are more of them are longitudinal studies. We have studies that have adjusted for potential confounders. And we have a broad range of international studies where other racialized societies or immigrants in multiple European societies have been studied. What we have found in this research is that discrimination is linked to a broad range of outcomes, such as C-reactive protein or coronary artery calcification or breast cancer incidence or carotid artery disease. It's also linked high levels of discrimination to delays in seeking treatment, lower adherence to treatment regimens, and lower rates of follow-up. Importantly, in the few studies that have actually examined the contribution of discrimination to racial disparities in health, have documented that this racial discrimination, the subjective experience, makes an incremental contribution over and above income and education in understanding racial disparities in health. So what can we do then about all these problems I have just outlined? What can every health professional do? Well, first of all, we need to reduce inequalities in healthcare. We need to improve access to care and the quality of care. We need to give emphasis to the prevention of illness and provide effective treatment. We need to develop incentives to reduce inequalities in the quality of care. But one of the key things we do as we begin to look at race and socioeconomic status and how we improve care for all, we really need to have some clarity in what race is and how we even use race in the healthcare context. A web survey done in 2005 found that the overwhelming majority of physicians in the United States believe that drugs targeted towards specific ethnic and racial groups offer therapeutic advantages. In fact, over 80% of physicians supported the FDA's approval of Bidal, a drug approved specifically to treat a condition in African Americans. And 81% of American physicians said that race should be used as a biological basis for determining certain ailments or diseases. Let's take a closer look at conventional wisdom. But before we do that, let's think of some of the limits of biology. Our racial categories predate scientific theories of genetics and modern genetic studies. And while there is genetic variation across population groups, our racial categories don't capture them well. In fact, we know that groups with same phenotypic characteristics can be very different genetically. As Nancy Krieger puts it, the fact that you and I know what race we belong to tells us more about our society than about our biological makeup. Or as Ruben Rombot puts it, race is a pigment of our imagination. So let's take a closer look at conventional wisdom. Every good clinician knows that knowing the race of a patient provides helpful information in terms of prescribing antihypertensive medications for that patient. That whites respond better to some medications than blacks do, and blacks respond better to other medications compared to whites. What is the basis for this? Ashwini Sehgal went back and looked at every clinical trial that had looked at racial differences in the impact of various antihypertensive medications. And what he found was that there was some truth to the conventional wisdom, that there were small average differences. That's the kind of reddish line, shows the average differences across race in terms of the impact on systolic blood pressure. The white, light-colored line shows the variation within whites, and the darker-colored line shows the variation within African Americans. The take-home message is that although there were small average differences by race, the variation within each race was 3 to 4 times the mean differences across racial groups. A similar pattern exists for diastolic blood pressure. In fact, Ashwini Sehgal calculated what percentage of whites and blacks respond identically to antihypertensive medication, and he found the overwhelming majority of them did. And he concluded that really, because the majority of blacks and whites respond similarly, and although there is a small mean difference, there's much more variation within each group, that simply knowing a patient's race provides precious little guidance to a clinician in the selection of antihypertensive medications. And it's just a warning to be very careful in how we use and misuse race in the clinical context. How can providers make a difference in improving America's health? We need to deliver care that addresses the social context. Care that addresses the social context needs to be primary care. Research reveals that access to regular primary care is associated with better health and smaller disparities in health. I want to give an example of care that addresses the social context broadly, and to think of the nurse-family partnership as one example. I cite this as an example because it's the quality of the scientific evidence we have. Randomized controlled trials in upstate New York and Memphis, Tennessee, in Denver, Colorado, where a control group received prenatal care and transportation vouchers to get to care. The intervention was to have a nurse visit these vulnerable pregnant women in their homes and take their condition seriously and understand it within the context of their lives. So the nurse not only talked about the pregnancy and taking care of an infant, but she also talked about the relationships, about employment opportunities, about parenting. And what the research shows is that a nurse-family partnership is linked to better health outcomes for both the mother and the child. And there's a $17,000 return to society for each family served. So it actually saves money and leads to improved health. I'll give you another example. Len Syme published a study in 1978. He took 244 patients, all of them low income, all of them hypertensive, 80% African American, randomized them to 3 conditions. Routine care, went to your doctor, got your hypertensive medication, sent on your merry way home. A health education intervention, in addition to routine care, you got a talk from a health professional about the importance of blood pressure. And the third group was an outreach group. They recruited lay people from the local community, trained them in basic information about blood pressure, but also provided them with a list of all the resources that existed in the community to help with problems that people might face. And these lay persons made home visits. After 7 months, they evaluated the 3 groups. Persons who received the lay intervention knew twice as much about blood pressure than the other 2 groups, so their levels of knowledge was higher. 2, persons who received the lay intervention were more compliant in taking their blood pressure medication than any of the other 2 groups. And 3rd, among good compliers, the blood pressure medication was more effective in keeping the blood pressure controlled. So everything a clinician would want, that your patient does what you ask them to do, that they understand their disease, and that the treatment works, all occurred in the context of those who had received the lay home intervention. And what was different about this group, their hypertension was being understood and addressed within the context of their lives. One of the challenges that providers face is that it's not enough to treat illness and send people back to live in the same conditions that made them sick in the first place. We need to comprehensively find ways to address some of the underlying social factors that lead to disease in the first place. And I want to give you 2 examples, both of them born at the Boston Medical Center in Boston, Massachusetts, of options that exist that clinicians can use to take a broader view of the social challenges that people face. One is the medical legal partnership. Dr. Zuckerman at the Boston Medical Center in the pediatrics unit developed the medical legal partnership. So at the Boston Medical Center, a pediatrician can refer a patient to a range of specialists. One class of specialists the pediatrician can refer the patient to is to on-site attorneys. The director of that program told me, show me a person who is poor, and I'll show you a person who has 2 or 3 legal needs, but have never defined them as legal problems. And so these lawyers can help the medical team in assisting families with social problems that can affect the effectiveness of the care provided and the management of the illness. A child with asthma in a moldy apartment will not breathe symptom-free regardless of the medications provided by the clinician without improved living conditions. And when a mother who has tried to get her landlord to do the right thing is unable to do so, a call from an attorney can make a difference. And so the attorneys collaborate at the Boston Medical Center with the physicians in addressing the social problems that patients face, and then can provide a higher quality level of medical service. The Medical Legal Partnership has just published a book, Poverty, Health, and the Law, with readings and cases of the power of medical legal partnership to improve the quality of medical care in the United States. Another program from the Boston Medical Center was called Project Health, and it's now called Health Leads. It was started by Rebecca Oni. She was an undergraduate student at Harvard, went to volunteer at the Boston Medical Center, and thought that there was more that could be done than was even being done. And so she developed this program of getting undergraduate students to volunteer in the waiting room of hospitals and clinics. And they would ask patients who came to the admitting desk 5 questions, assessing some of the social challenges they face, like problems with housing and problems accessing food. These volunteers, having identified a problem that a client has, it is their job to fill the prescription for food assistance, for housing improvement, by connecting those patients to local resources. For her work, Rebecca Oni received the MacArthur Genius Award. And today, the Project Health Leads is currently in the waiting rooms of 23 hospitals and clinics in different states in the United States. It's another attempt using undergraduate student volunteers to more comprehensively address the problems that patients face. Improving America's health also means all of us need to lead healthier lifestyles. We need to improve our behaviors that in fact drive good health, like reducing smoking, improving nutrition, reducing obesity, increasing exercise, reducing alcohol misuse, improving sexual health, improving mental health. How well are we doing? I looked at the CDC data, the most recent report. The CDC and NCI and the government agencies that have looked at the evidence recommended that all Americans should eat 5 servings of fruits and vegetables per day. And this is the latest data, that no group of Americans, not even the college educated, not even 40% of not even the majority of the college educated, are eating 2 or more servings of fruits per day. For vegetables, the data is not much better. Again, not even the college educated are consuming 3 or more servings of vegetables a day. All of us could be doing better in terms of health. Based on the latest evidence, the National Cancer Institute recommends that we really need not 5 servings of fruits and vegetables a day, but 9, and shows that it's possible. We aren't even getting the 5. The challenge of getting 9 will be even a greater challenge. The China Study is a recent book on the nutritional challenges Americans face and its contribution to a problem of chronic disease. The back cover of this book makes the point that the epidemic of chronic illness in the United States is caused, according to this book, by three problems. The three problems are breakfast, lunch, and dinner in the United States. So there are enormous opportunities for us to improve health by improving our diets. Obesity is a major challenge. For the first time in history, some estimates suggest, we are facing the prospect of raising a generation of Americans who will live sicker and shorter lives than their parents because of the obesity epidemic. And obesity is causing a dramatic increase in healthcare costs and a dramatic increase in diabetes in the United States. At the same time, the evidence is also clear that as we seek to improve our behaviors, just saying no campaigns are not enough. The experience of the last 100 years has taught us that interventions that narrowly focus on the behaviors themselves alone without taking the broader context into account are not likely to be effective. So while all of us need to make healthier choices, there's also a need for social responsibility. There is a need for individual responsibility. There's a need for social responsibility. We need to create the opportunities that promote good health for all. We have to remove the barriers that make it almost impossible for some Americans to make healthy choices. And our experience with cigarette smoking suggests some pathways. We have made some progress, although smoking is still a big problem. We have made some progress on the front of cigarette smoking, but it has taken the entire society working together through multiple intervention channels, through multiple organizations, by informing the public, by providing economic inducements, by using laws and regulation, multiple sectors of society focused on one problem, and even then, our success has only been partial. We need to move upstream and get at some of the fundamental determinants of health. Where we live, learn, work, play, and worship determine our opportunities and chances for being healthy. In fact, the research suggests that where we live, learn, work, play, and worship have more to do with our health than going to the doctor. Going to the doctor is important. Going to the doctor is of great value, but our healthcare system focuses on taking care of us once we are sick. To a large degree, it's a repair shop. The question is, what makes us healthy in the first place? And the opportunities and chances for being healthy in the places where we spend most of our time is crucial. One of our challenges for health policy, then, is for us to figure out how can we make the healthy choice the easy choice, the healthy choice the default choice. And it means we have to address some of the broader issues that shape health. Partly what I'm saying today is we have to completely redefine what health policy is. Health policy is policy in all sectors of society that affect our opportunities to choose health. Housing policy is health policy. And employment policy is health policy. And community development policy is health policy. And educational policy is health policy. Health policy is policy in areas that lead us or shape our chances for being healthy. What it will take then is for all of us to work together to create a new culture of health. Living healthier requires a new culture that emphasizes health. Many argue we live in an obesogenic culture. We need to live in a healthy culture. We need to better incorporate health into our homes, our schools, our workplaces, our neighborhoods. Safety and wellness needs to be integrated in every aspect of community life. Health needs to be factored into all policy making. It means that doctors alone, or public health persons alone, or nurses alone cannot improve health. We need to work across sectors of society, working together to improve the health of all. Is it possible? I'll give you an example of the state of Pennsylvania's approach to the crisis of food deserts, large areas with no access to food. The state of Pennsylvania allocated $10 million a year for 3 years, $30 million, leveraged by the Fresh Food Financing Initiative into $200 million. And in the state of Pennsylvania today, there are 58 new supermarkets in areas that didn't have supermarkets before. I was privileged to visit, as part of my work with the Robert Wood Johnson Foundation's commission, ShopRite supermarket in a poor African-American neighborhood led through this supermarket by Jeffrey Brown, the owner of 10 supermarkets in the greater Philadelphia area. This was a large 65,000 square foot supermarket that existed in this poor black community that had been without a supermarket for 30 years. And Jeff Brown, I call him an angel because he is a capitalist. He wants to make money, but he has blended the ability to make money with a level of concern for community issues that is remarkable. He has the same price in all his 10 stores, the same hours in all the stores. The stores in the inner city community has a community room that is available free to any community group that wants to hold a meeting. He's a good community citizen. So every store manager of a department in the store, has to serve on a local community board. He works for 2 organizations and hire ex-offenders so that they can work and hold full-time jobs in his store. Every quarter, he runs a Gifts for Guns program, where for every gun handed in from off the street, there's a $100 voucher to his groceries in his store. And what he has found is there's no higher level of theft in his inner city store. They're higher training costs, but low turnover. If you open the store, the same volume of fruit and vegetable sales as in his suburban stores, higher poultry and fish sales. And the store has served as an engine of economic development in the community. Property values has increased. It has attracted other retail interests. Seniors can walk to the store. It provides employment to the local community. It has attracted more capital, and he has used the store as an outreach center where other services can come and co-locate and provide services to the community. We can do things to improve health if we want to. Another example, very different, coming from Brigham and Women's Hospital, a hospital right next to my school in Boston, where the researchers implemented an intervention to reduce the consumption of high-sugar drinks in the cafeteria. They posted flyers in strategic locations in and around the cafeteria that carried this message: you can lose 12 to 25 pounds a year simply and decrease your risk of diabetes by one half, just by skipping 1 regular soda per day. For 0 calories, try diet soda or water. Powerful message. But what they found as they monitored the sales of high sugar drinks in the cafeteria, this campaign had no impact on consumption of high sugar drinks. And so they tried a second strategy, a price increase of 35%, adding 45 cents to the price of every high sugar drink, and it led to a 26% decline in sales. I'm not sure that price increases are the only strategy, but it's an example of the kinds of strategies we have to do and the thinking out of the box that we need to do in terms of creating this culture of health that is so important. What else do we need to do? We need to work on creating healthier communities. Place matters. Where you live in the United States determines whether you live in a healthy community or an unhealthy community. What would happen if we could improve the quality of neighborhood environments? If we intervened and improved neighborhood environments, would health improve? We now have evidence from studies in Europe and studies in the United States, high-quality experimental studies that shows simply by changing an individual's residential environment, no intervention in terms of health leads to better health. Moving to opportunity is one example of that. 3 years later, poor families randomized to receive a housing voucher where they moved to a less poor neighborhood witness improvements in mental health of the parents and the boys. 10 to 15 years later, a recent paper just published in New England Journal of Medicine, there's a lower levels of obesity, both overall obesity as well as severe obesity, and lower levels of diabetes risk among those who were moved. But folks, you shouldn't have to move to live in a better neighborhood. We need to find ways where we can invest in the quality of our neighborhoods, provide an infrastructure that provides opportunities and improves the quality of life. The social, physical, economic infrastructure of disadvantaged communities is an important strategy of improving health. We also need, as a health improvement strategy for the nation, to enhance the quality of education and improve economic well-being. We know what to do to improve education. The Education Trust, in this powerful booklet called Yes We Can, Telling Truths and Dispelling Myths About Race and Education in America, has identified the strategies that exist and points to examples of schools on American Indian reservations, in poor Latino communities, in poor African American communities that are successful in producing students who are well trained. We know what to do. We need to make the investment to do it. We also need to improve economic well-being in general as a health improvement strategy. A task force from the Center for American Progress has outlined a roadmap how we can cut poverty in half in the United States in 10 years. We know what we need to do. The question is, do we have the political will to do it? The other question someone might have, would it work? Would it really make a difference if we improved economic well-being? We now have high-quality scientific evidence from, for example, the conditional cash transfer program from Mexico, where Mexico has improved health in poor communities by providing additional income to low-income residents. And using an experimental design, have documented that the additional income alone has led to improvements in terms of health. One of the other things we need to do is to improve early childhood development programs. They have been shown to have an enormous positive impact in terms of health. One of the examples is the Perry Preschool Project, where poor African American kids were randomized to receive an early childhood intervention. They have now been followed for 40 years. 40 years later, those who receive simply a preschool intervention have higher academic performance, higher levels of income, more likely to own their home, more likely to be married, less involvement with the social service system, less involvement with the criminal justice system, and for every dollar invested in the program, there's a $17 return to society. So it works, and it saves money at the societal level. We also know that economic policy is health policy. In the last 50 years, if you monitor black-white differences in health, they narrowed whenever black-white differences in economic circumstances narrowed, and they widened when black-white differences in economic circumstances widened. There's research documenting the health benefits of the civil rights movement in terms of improving health. Between the mid-1960s and the mid-1970s, during the very time that the economic circumstances as measured by household income improved for African Americans relative to whites, we had the health of blacks improving more rapidly than the health of whites, so that the gap absolutely narrowed. It widened during the decade of the 1980s. What can we do to sustain action? What can we do to make this real? We need to identify and nurture a core of champions in the public, private, and voluntary sectors. We need to develop and maintain a steady drumbeat of policy-relevant information about the importance of addressing broadly the factors that determine health. We need to pay more attention to how we communicate effectively with policymakers and the engaged public about the importance of these strategies. And we need to emphasize interventions. People want to see strategies that work. We need universal policies that improves the health of all, even as we focus on targeted interventions to close the gaps and help the most vulnerable. There are a range of good reasons to improve America's health. If the moral reasons aren't good enough, I want to give you one final reason: the cost. These disparities in health are costly to the U.S. One estimate from the Joint Center for Political and Economic Studies estimates that racial inequalities in the U.S. cost the U.S. economy $309 billion a year. A recent paper led by two economists who both served in the President's Council of Economic Advisors documented that the gaps in health by education are costing the U.S. economy $1 trillion a year. If all Americans had the health of the college-educated, the U.S. economy would save $1 trillion annually. I want to let you know that there are a range of resources to help you engage in this work. The Robert Wood Johnson Foundation's Commission to Build a Healthy America has a report with a range of strategies that's available on this commission's website, commissiononhealth.org, in terms of strategies that we can use to improve America's health. County health rankings available at countyhealthrankings.org list the levels of health in every county in each of the 50 states and the determinants of health in each county. It provides data at a local level that can be used to improve health. The Unnatural Causes PBS series is a wonderful documentary to engage and inform both professionals and community workers. The MacArthur Foundation's Research Network on Socioeconomic Status and Health produced a volume in the New York Academy of Sciences Annals called The Biology of Disadvantage that provides a scientific background and links the biological mechanisms through which the broader social environment affects health. I'm saying we are faced with two challenges. A research challenge. We need a more integrated science so that we can better understand how multiple dimensions of the social and physical environment combine additively and interactively with each other and with innate and acquired biological factors accumulate over the life course to affect the onset of illness and the progression of disease. But probably our biggest need is to apply the knowledge we currently have to improve America's health. Health system reform is critical, but insufficient to address the challenges we face. Social factors like education, housing, transportation, and the environment have decisive impacts on health. There are promising approaches from around the country right now that can be used to improve the quality of life and thus the health of all populations. Health professionals cannot do the job alone, but we need to work together with other sectors of society to bring resources together in a concerted way to modify and improve the quality of life in the places where we live, learn, work, play, and worship. And we need to attend to those who are farthest behind. Edmund Burke has reminded us that the only thing necessary for the triumph of evil is for good men and women to do nothing. I believe that we are good men and women, but then we need to get up from this place and go forth to make a difference, to work together in our sphere of influence to improve the lives of all Americans. I wish you success as you undertake this work. Thank you very much.